Hello everyone. In this video, I'm going to cover counseling of the pregnant patient and antepartum hemorrhage. But before that, we have a little topic left from fetal surveillance, which is biophysical profile. So I'm going to cover that. Let's head towards our topic. One more thing. In the first video of obstetrics, I explained this prenatal screening and the diagnostic tests. Right in here, there is a table which compares the enhanced first trimester screening, maternal serum screening, and IPS. So I'm just gonna talk a little bit about it quickly because I remember that we mentioned that these screenings, the first trimester and maternal serum screening, these estimate the risk of trisomy 21, which is down, and trisomy 18, which is Edwards. So I remember talking about it, but I had a little, what you can say is cheat code to remember these, the risk estimate, to remember the values of it. So I'm just gonna quickly explain it, and then we'll head towards our today's topic. So in the EFTS, which is the enhanced first trimester screening happening in 11 to 14 weeks, what we measure is nuchal translucency, beta HCG, and PAP-A. Right? And in our maternal serum screening, which happens around 15 to 20 weeks, we go for maternal serum alpha-fetoprotein, we go for estradiol, beta HCG again, and inhibin A. So there is a little cheat code. I've just summarized EFTS in beta HCG, PAP-A, and MMS in maternal serum alpha-fetoprotein, beta HCG, inhibin A, and estradiol. Nuchal translucency is supposed to be increased in both of them. Okay. Other than that, for downs, I like to remember it this way, that everything would be down except the words which have an H in it. So those would be high. I know it doesn't make any sense, but it's just a mnemonic for me. So everything would be down except the things which have, except the markers which have H in them. So beta HCG would be increased, beta HCG in maternal marker screening would be increased, and inhibin A would be increased too. But PAP-A would be down, maternal serum alpha-fetoprotein would be down, and estradiol would be down. But in Edwards, everything would be down. So we're just gonna tally it here. From here, 21, nuchal translucency is supposed to be increased in both of them. Okay, beta HCG was increased in down because it has an H in it, and then PAP-A is decreased because everything is decreased. For down, it is in purple, so decreased maternal serum alpha-fetoprotein, increased beta HCG, decreased estradiol, and the inhibin A is also increased. I'll look into it right here. The main inhibin A multiple of the median was significantly higher in Down syndrome group than in the euploid group. So inhibin A is also increased. I just confirmed it. Other than that, trisomy 18, which is Edward, of course, nuchal translucency would be increased, but everything else, which is marked by blue, decreased PAP-A, decreased maternal serum alpha-fetoprotein, decreased beta HCG, decreased estradiol, and decreased inhibin A. So that was a quick mnemonic, or whatever you can say, to remember it. Okay, moving forward, talking about biophysical profile. So this is basically a non-invasive test just to check the baby, just to check our fetus, just for the fetal surveillance. And this biophysical profile test includes an ultrasound. It is non-invasive because we're just gonna do an ultrasound, and it can include the non-stress test, which I discussed in the previous video. This non-stress test, it can include in it. And we usually do include that too. Okay, so what we do in biophysical profile, we just do an ultrasound of the fetus, and we measure the tone, the movements, breathing, and amniotic fluid volume. Each of these parameters have 2 points. That would make a total of 8, but we Rate biophysical profile usually out of a 10 because there's a parameter of 2 more scores, which is fetal heart rate, which we get from the non-stress test. Okay, now when do we do biophysical profile? The indications are if the pregnancy is post-term, if the fetal movements are decreased, if you feel that there is intrauterine growth restriction, or any other suggestions of fetal distress or uteroplacental insufficiency, we go for fetal surveillance via biophysical profile. Okay, what is the criteria? Tone has 2 scores. So while doing that ultrasound, at least 1 episode of limb extension followed by a flexion. So limb extension followed by a flexion. And then we have movement. 3 discrete movements should be there. 3 discrete movements would make it reassuring, and we can give them 2 points. This parameter would be reassuring. So this is movements. And then breathing. At least 1 episode of breathing lasting at least 30 seconds. So there should be 1 episode of breathing. And then amniotic fluid volume, fluid pocket of 2 centimeters in 2 axes. So what we do in this case is we just do the ultrasound assessment, and we try to find a fluid pocket which is the deepest, which doesn't have any fetal parts, not even umbilical cord, and then we measure their axis. So in at least 2 axes it should be 2 centimeters, so it should be 2 into 2 centimeters. So that would be a reassuring amniotic fluid volume. So B is breathing and A is amniotic fluid. So it makes LAMB, which is a mnemonic right here. Reassuring, biophysical profile, limb extension plus flexion, amniotic fluid volume 2 centimeter into 2 centimeter, movements, breathing. So that's reassuring biophysical profile. Moving forward, how do we interpret it? So if we have a score of 8 by 10 or 10 by 10, that is pretty normal. Even 8 by 10 with normal fluid is good. Okay, there is decreased mortality rate, intervention of obstetric and maternal factors if there are any. Then moving forward, if it is 6 or 8, okay. So if we have 8 score and fluid is normal, no worries. But if we have a score of 8 but fluid is abnormal, or even if we have a score of 6 and fluid is abnormal, what do? We have to check the fluid. How do we do that? We determine the function of renal tissue of the fetus. We determine if it's properly working, if the fluid is producing in a good amount, the amount which is enough. And secondly, we check membranes, that what if it's producing normally but it's not being sustained there, membranes are not intact. Okay, moving forward, if function is normal and the membranes are intact, then if the fetus is at term, we'll deliver the fetus. But if the fetus is at less than 34 weeks, then we continue surveillance of the preterm fetus. And if it is 6 by 10 with normal fluid, so this was 6 by 10 with abnormal fluid, 6 by 10 with normal fluid, then that's an equivocal test. It's uncertain. We have to go for a repeat test. So this test didn't decide anything for us. So we'll repeat the biophysical profile in the next 24 hours. So till 6, we can say that it's okay. We are repeating. There is no specific indication of fetal compromise. But we had to do something when we found abnormal fluid. Alright, now 4 or less than 4 has a perinatal mortality rate of 91 to 600 to 1000. So consider delivery for fetal indications. If we see any fetal hypoxia for fetal indications, we will consider delivery. So that's a bad score. This is biophysical profile. Let's move ahead towards counseling of pregnant patient. In counseling, we're going to consider nutrition and lifestyle. With that, we're also going to talk about medications, immunizations, radiation. That's it. I'll move through this topic pretty quickly. Nutrition, Canada's Food Guide to Healthy Eating suggests that the pregnant ladies should eat a varied diet, which must include vegetables, fruits, whole grains, dairy products, lean meats, plant proteins. And the caloric intake is increased by almost 100 kilocalories per day in the first trimester to 300 kilocalories per day in the second and third trimester, and we would say 450 kilocalories per day during lactation. And you are supposed to take multivitamins and folic acid throughout your pregnancy. Nutrients in pregnancy, we're just gonna give these additional supplements: folate, calcium, vitamin D, iron, and essential fatty acids. Folate, it should be 0.4 to 1 milligrams daily in all women, and it should be started before conception, 2 to 3 months preconception, and 4 to 6 weeks, which is about 1.5 months postpartum. So 2 to 3 months before and 1.5 months postpartum, 4 to 6 weeks postpartum. And that's for everybody. But if the women have high risk of neural tube defects, then we are going to go for 4 milligrams of folate. That should be started at least 3 months preconception, and for 4 milligrams you're going to take that until 12 weeks. After 12 weeks, you can start continuing 0.4 to 1 milligrams of folate, because the first 12 weeks are very critical. Organogenesis is happening, so we have to be very careful about folate. We have to be very careful and cautious about the neural tube defect. So we are taking 4 milligrams. And then after 12 weeks, we can get back to 0.4 to 1 milligrams. And then 4 to 6 weeks postpartum as per usual. And you can take it as long as you're breastfeeding. Okay, what does it do? It supports increase in the blood volume, growth of maternal or fetal tissue. It decreases any incidence of neural tube defects. And which foods have them? Spinach, lentils, chickpeas, and the list goes on. Calcium, it should be 1200 to 1500 milligrams per day. Of course, it's there to maintain integrity of maternal bones and then fetal skeletal and breast milk production too. So 1200 to 1500 milligrams per day. Vitamin D, that will help to absorb that calcium, 1000 international units. Iron, it should be 0.8 milligrams per day in the first trimester, but then it gets to 4 to 5 milligrams per day in second trimester and more than 6 milligrams per day in the third trimester. So iron is the only known nutrient for which requirements during pregnancy cannot be met by diet. You have to take that as supplements. By diet alone, you cannot fulfill the requirements. And we have read that the woman's body undergoes some physiological adaptations, which lead to which includes hemodilution too. So we have to, the iron supplements, the iron stores in the body are not enough for they do not fulfill the requirements. So we need supplemental iron. That would help to support maternal increase in blood cell mass, and it also supports fetal and placental tissue. So fetal and placental and maternal, so it supports everything. So it is pretty important to take, starting from the first trimester, start taking like almost around 1 milligrams per day, then 4 to 5 milligrams per day, and then more than 6 milligrams per day in third trimester. So it varies from trimesters. And then we have essential fatty acids that supports fetal neural and visual development. And it might be possible that it's included in the vegetable oils and margarines and peanuts and fatty fish. Caffeine is a diuretic and a stimulant, and it readily crosses placenta. You don't want your baby to be receiving diuretics and stimulants. So you have to control its amount. You have to restrict its intake. Less than 300 milligrams per day is considered safe. And that would be 1 to 2 cups per day. In pregnancy, it is considered to be safe. Herbal teas and preparations. For that, there is not enough scientific information. It can cause toxic or pharmacological effects on mother or fetus. Raspberry leaf tea, often used as term to promote labor. So herbal teas can be considered safe, but it should be in moderation, 2 to 3 cups a day. But there's no scientific information how safe those are to recommend during pregnancy, so we do not recommend it. Moving forward, talking about the foodborne illnesses, we have to be cautious about listeriosis and toxoplasmosis. So we all know toxoplasmosis comes from the pets, especially from the cats. So you have to stay away from cats' litter. especially for the pregnancy time. And moving forward, avoid consumption of raw meats. So any kind of raw things, avoid it, and avoid unpasteurized products. Okay, that can be a source of listeria. Other than that, chemical contamination of food, current guidelines for mercury of 0.5 ppm in fish is not considered harmful for the general population, including pregnant women. So for current guidelines, if you find this much mercury in fish, it is not considered harmful, but Health Canada advises pregnant women to limit consumption of top predator fish. Okay, all right, so that was all about nutrition. Now the pregnant lady is here, your patient is here, and you have to counsel them about your lifestyle. These two topics are very important for NACOSCI too. With QE1, they are also important for NACOSCI. So now we're going to counsel them about lifestyle. So there are various bullet points. I have made some stars: physical activity, weight gain, work, air travel, sexual intercourse, smoking, alcohol, cocaine, cannabis, biopsychosocial considerations. So physical activity, it should be 150 minutes of moderate intensity per week. So don't forget moderate intensity. And there's a talk test. It's like the patient, you'll tell them that you should be able to talk, you should be able to speak while you're exercising. That would tell that, okay, it is moderate for you. And avoid supine position after 20 weeks of gestational age. There are some absolute contraindications of physical activity, and these are important for MCQs for QE1. Which are the situations in which physical activity is contraindicated? Absolutely. So if you have ruptured membranes, if you have preterm labor, hypertensive disorders, incompetent cervix, intrauterine growth restriction, multiple gestations, which is more than 3, placenta previa after 28 weeks gestation. After 28 weeks gestation is important because usually if we diagnose placenta previa in first and second trimester, there are chances that it can get resolved. I'm going to teach that in the next topic. But if you diagnose placenta previa, if it's still there after 28 weeks, stop exercising. It is an absolute contraindication. Persistent trimester second and third bleeding, uncontrolled diabetes, so hypertensive and diabetes, both of them, uncontrolled thyroid disease, serious cardiovascular respiratory disease, and other systemic disorders. So these are some absolute contraindications of physical activity. But there are some relative contraindications too if the patient has recurrent pregnancy loss, gestational hypertension, which is less than 20 weeks, diagnosed less than 20 weeks, history of spontaneous preterm birth, cardiovascular respiratory disease, anemia, malnutrition, eating disorder, twin pregnancy after 28 weeks gestation, you should stop. In third trimester, you should relatively stop that physical activity, stop exercising, which we were doing 150 minutes per week. Okay, and other significant medical conditions. All right, and in twin pregnancy, it is relative contraindication, but if it's more than 3, then it is an absolute contraindication. Okay, work. If you're working strenuous or extended hours, then there is a greater risk of low birth weight, prematurity, and spontaneous abortion. So you have to be careful about it. Air travel. It is acceptable till second trimester, and some airlines have a cutoff for travel in 36 to 38 weeks because it is pretty close to term, so they don't want a delivery in their plane. So 36 to 38 weeks is a cutoff for most of the airlines. Sexual intercourse, it may continue, except in the patients at risk for spontaneous abortion, preterm labor, or placenta previa. So you have to remember these contraindications. If there is a history of spontaneous abortion, preterm labor, or placenta previa, then it is an exception. Breast stimulation may induce uterine activity and is discouraged in high-risk patients, especially near term. So moving forward, we're going to talk about smoking. Assist, encourage to reduce or quit smoking. Increased risk. What does what can smoking cause in pregnancy? It can cause decreased birth weight of your baby, placenta previa. Placenta would be either, there would be abruption. It could cause spontaneous abortion, preterm labor, stillbirth. So it can cause increased risk of many of the complications. Psychosocial interventions should be considered the first line, but nicotine replacement therapy can also be used. And then you can think of pharmacotherapy, but you have to use lowest effective dose so that there's minimal fetal exposure. Alcohol, no amount of alcohol is safe in pregnancy. Let me highlight it. No amount of alcohol is safe in pregnancy. Encourage abstinence from alcohol during pregnancy. Alcohol increases incidence of spontaneous abortion, stillbirth, congenital anomalies. So smoking also increases that spontaneous abortion, preterm labor, stillbirth. But alcohol includes congenital anomalies like fetal alcohol spectrum disorder. Cocaine, it can increase risk of microcephaly, growth retardation, prematurity, placental abruption. So placental abruption comes here too, comes in smoking too. Cannabis associated with low birth weight, just like smoking, decreased birth weight. And just like strenuous work, decreased birth weight. So cannabis, low birth weight infants, and risk of neurobehavioral abnormalities. And then biopsychosocial considerations. These include your mood, your work, your stress from your work, your family. So you have to adjust them in your pregnancy. So we can go with the birth plan if you're worried about, if the patient is worried about it, or we can also refer them to counseling or community resources as needed. I skipped weight gain, right? Yes, right here. Weight gain. Optimal gain depends on pre-pregnancy BMI. So it usually depends on pre-pregnancy BMI. Depending on the pre-pregnancy BMI, you gain weight. It varies somewhere between 6.8 to 18 kilograms. So almost 7 to 18 kilograms. But depending on the BMI, it varies. So the normal BMI 18.5 to 24.9, total gain in second and third trimester would be 25 to 35 pounds. You could say it's 1 pound per week. So either just remember this, if you have a lesser BMI, then you're gaining weight more than normal, 1 to 1.3. If you have higher BMI, then you're gaining weight less than normal. So it's pretty much dependent on the pre-pregnancy BMI. But this is more or less how much you gain. It varies, but more or less this is how much. 6.8 to 18.2 kilograms. So that's lifestyle. Moving forward, we do have some medications too. Most of the drugs cross the placenta to some extent. So you have to be cautious about drugs. And you should only take them whenever necessary. So if you're going to some doctor and you're not sure that they know you're pregnant or not, you have to. Of course, there are some forms in which you are required to tell them if you're pregnant or not, but I would say that the patients should be responsible for this, and they should be informing that they are pregnant, because there are many medications which are totally contraindicated. We have some list of contraindicated medications, starting with ACE inhibitors, which can cause renal defects. Then carbamazepine, open neural tube defects. I marked carbamazepine and valproate. Both of the antiepileptics would be causing open neural tube defects. I wonder if phenytoin does the same or not. Anyhow, then chloramphenicol, gray baby syndrome. I do have that open in one of my tabs right here. Gray baby syndrome, also termed gray or gray syndrome, is a rare but serious side effect that occurs in newborn infants because of the lack of this enzyme. Then baby cannot really excrete via the kidneys this unconjugated drugs. So they turn pale or blue skin, lethargic eyes, and they do have vomiting, hypotension, cyanosis, hypothermia, cardiovascular collapse, and irregular respiration. So cardio, respiratory, and then hypertension, vomiting, so the loss of appetite. So these are the symptoms of gray baby syndrome. That would be because of chloramphenicol. And then we have lithium. So lithium would be a cause of Epstein's cardiac anomaly. Misoprostol, it would cause Mobius syndrome, congenital facial paralysis with or without limb defects. So I do have Mobius too. So that is a congenital defect in which we would see facial paralysis, incompletely closed eyes, inability to move eyes, crossed eyes, and then maybe some limb abnormalities too, like hand and foot webbing. So Mobius includes facial and limb abnormalities. Facial paralysis without or with limb defects. Misoprostol can also cause spontaneous abortion or preterm labor. Then we have NSAIDs, premature closure of ductus arteriosus after 30 weeks gestation. That's premature. Phenytoin, fetal hydantoin syndrome. So this is what it includes: growth restriction, mental retardation, facial dysmorphogenesis, and some congenital anomalies. So phenytoin would be causing fetal hydantoin syndrome. I have something for that too, I believe, right here. So phen is the mnemonic, phenytoin. P would be palate, because there was facial dysmorphogenesis, so cleft palate or cleft lip. Then H, small head, hypoplastic face, so facial dysmorphogenesis. And then H is for heart defects too, so congenital anomalies. E is embryopathy, and it was because of the anti-epileptic use, which is phenytoin. And N is hypoplastic nails or neurological deficits. So growth restriction, mental retardation, facial and congenital anomalies. That's phenytoin. Retinoids are also contraindicated. They can cause neural defects. Sulfa drugs, they have antifolate properties. They can increase the risk of kernicterus. Tetracycline stains and fans teeth, and it may also infect the long bones. Then warfarin, it can induce spontaneous abortion. It can increase the incidence of stillbirth, prematurity, IUGR, fetal warfarin syndrome, in which there is nasal hypoplasia, epiphyseal stippling, optic atrophy, mental retardation, and intracranial hemorrhage. So that's a whole syndrome which is called as fetal warfarin syndrome. There would be nasal hypoplasia, epiphyseal stippling, so problems with the bones, optic atrophy, problem with the eyes, mental retardation, and intracranial hemorrhage because of this anticoagulant warfarin. All right, moving forward, talking about immunizations. This is a pretty important topic. We do have many MCQs coming from here. So what we do is classify it in intrapartum and postpartum. Talking about intrapartum, administration is dependent on the risk of infection versus the risk of immunization complication. So, if it's better to have that infection, if risk of infection is not that bad, then don't get the vaccination. But if risk of immunization is like pretty bad, don't get it. But if risk of immunization has no specific complications, then we'll immunize during intrapartum too. Okay. There are the vaccines which are safe, like tetanus toxoid, diphtheria, influenza, Hep B, and pertussis. So we can give pregnant ladies tetanus toxoid, diphtheria, pertussis, which is Tdap. And then we can also give hepatitis B, and we can also give influenza, but which is the inactivated one. Okay, we cannot give activated one. Then this is the most important thing. You have to avoid live vaccines because there is a risk of placental and fetal infection too. So you have to avoid live vaccines like polio, MMR, and varicella. And oral typhoid vaccine is contraindicated. So just remember this, oral typhoid is contraindicated. Public Health of Canada recommends that all pregnant women receive the influenza vaccine. So we have to remember that this is part of our recommendation that we will give influenza vaccine to all pregnant women. And all pregnant women should be given Tdap every pregnancy, irrespective of if their immunization history, if they had it before or never had it, you have to give them Tdap. So influenza and Tdap. And that should be ideally between 27 to 32 weeks, but it can be given earlier if we have risk of preterm labor. So these are the two indications, like must points, influenza and Tdap, but there's a contraindication, oral typhoid, and then we have to avoid live vaccines, which include polio, MMR, and varicella. What about postpartum? MMR includes rubella, which is contraindicated, but rubella vaccine can be given postpartum for all non-immune mothers. If they have had an adult booster and remain non-immune, they should not be revaccinated. So if they had an adult booster, do not revaccinate them. But whenever you vaccinate them, you should be deferred. The pregnancy should be deferred. You should inform them that the pregnancy should be deferred for at least 1 month. Now we are vaccinating you with rubella. Try not to conceive. Pregnancy should be deferred for at least 1 month. So that's important for rubella. And then Hep B vaccine should be given to infants if within 12 hours of birth, if the maternal status was unknown, or if it was positive, or if dad was the carrier, dad has some chronic Hep B infection, so it should be given within 12 hours of birth, and then 1 month, and then 6 months. You can also delay the postpartum vaccinations if the patient is receiving some immunoglobulins like ROGAM, or because of some hemorrhage or anemia, if the patient is receiving some blood products. So we can also delay the postpartum vaccinations. But rubella vaccines are important for all non-immune mothers. If the mother is non-immune, give them rubella postpartum. And Hep B we talked about. Okay. We have some questions regarding immunization. It says UWorld, page 33. Okay. All right. 25-year-old woman, gravida 2, para 1, 24 weeks gestation, comes to the office in mid-November for a routine prenatal visit. So it's a 24 weeks gestation and routine prenatal visit. She has felt normal fetal movement, no abdominal pain, vaginal bleeding or leakage. 3 days ago, the patient's 5-year-old son was diagnosed with varicella. However, she has not had fever, malaise, or a rash. Patient has no chronic medical issues or previous surgeries. She takes prenatal vitamin and iron supplement. Patient does not use tobacco, alcohol, or illicit drugs. Blood pressure is 110/60, pulse 64, BMI 27. Physical examination shows no rash or lymphadenopathy. Fundal height is appropriate for gestational age. Fetal heart by bedside Doppler is 145 per minute. Patient's prenatal laboratory results are as follows. So we look into the infections, the immunity. Rubella IgG and rubella IgM are both negative. Varicella zoster IgG is positive, but zoster IgM is negative. Administration of which of the following is the best next step for this patient? Haemophilus influenza type B, influenza virus vaccination, MMR vaccine, varicella vaccination, varicella zoster immunoglobulin. We have read that influenza virus vaccination is important for all the pregnant ladies. It is to be given. We read influenza. Sorry about that. We read influenza and we read Tdap. So we're going to give any of these if there's any option. MMR, even if rubella is negative, you are not going to give in pregnancy because it's a live vaccine. It can increase risk of infection in the baby. Varicella vaccination, you cannot give. And Haemophilus influenza, we talked about it that we could give, but not the activated form. So, vaccines during pregnancy recommended are Tdap, inactivated influenza, and the ROGAM, which is important for specifically for Rh negative mothers. Indicated for high-risk patients, you can give Hep B, Hep A, pneumococcus, Haemophilus influenza, which is inactivated meningococcus, varicella zoster immunoglobulin, not the vaccination. Varicella vaccination is contraindicated. You can give the immunoglobulin. But this lady already had that. She has immunity against it because IgG is positive. So we don't have to give immunoglobulin. we can give influenza virus vaccination. So there are a few contraindications more. We read MMR, we read live attenuated influenza. In Toronto notes, we can also add human papillomavirus vaccination. Okay, I'll just give a quick read. Maternal vaccination is beneficial for both mother and fetus. Optimal time for administration is prior to conception. Vaccinations during pregnancy are indicated if the vaccine has minimal risk, if significant risk exists for infection exposure, or if increased morbidity and mortality are associated with infection. Vaccines are safe during pregnancy include immunoglobulins, toxoids, and inactivated vaccines. Live attenuated vaccines are contraindicated during the pregnancy. All pregnant women without contraindications should receive the influenza vaccination as soon as it becomes available. Inactivated influenza vaccine is safe during every trimester and also while breastfeeding. Okay, option A, Haemophilus influenza type B vaccine, an inactivated vaccine, is safe in pregnancy. However, it is indicated only in the unvaccinated or high-risk patients. So we didn't know that if this patient was unvaccinated for it, Haemophilus influenza or type B vaccine, or she's high risk. MMR is contraindicated. Patient is not immune to rubella as evidenced by negative. The MMR is a live vaccine and is contraindicated. This patient should be contraindicated. This patient should be vaccinated in the immediate postpartum. So if we had an option that we can vaccinate them in immediate postpartum, then we could use that one. Select that one. Okay, and then varicella in pregnancy can be associated with maternal complications, example pneumonia, meningitis, encephalitis. These are the maternal, and then there are many congenital too, like cataracts, chorioretinitis. So patients who are exposed to varicella but lack evidence of varicella immunity, negative IgG, are treated with post-exposure prophylaxis. So if they lack evidence of varicella immunity, then we'll give them post-exposure prophylaxis. In pregnancy, post-exposure prophylaxis includes the immunoglobulin administration. The varicella zoster vaccine, a live attenuated vaccine, is contraindicated. This patient has had a recent varicella exposure, but her testing suggests immunity. She does have IgG antibodies, so we do not need the immunoglobulin because she already has immunity. Make sense? So vaccines that are safe: influenza, Tdap, Rogam. The inactivated seasonal influenza vaccine is safe during every trimester and should be administered to all pregnant patients as soon as it becomes available. Moving forward, we have one quick question. Let's just try to make these videos as short as possible, but alright. 27-year-old premi-gravid woman at 16 weeks gestation comes to the office for an initial prenatal visit. She has had no pelvic pain, vaginal bleeding, or abnormal discharge. This patient immigrated to the United States 6 years ago. She has no medical issues or previous surgeries, regular menses, no STIs, family history is non-contributory, takes vitamins, no tobacco or alcohol, illicit drugs, blood pressure, BMI, fetal heart rate, everything appears normal. Blood type is O, R is negative. Rubella and varicella titers both show no immunity. So both of them show no immunity. Hemoglobin is 11.2, mean corpuscular volume is 84. All routine labs are normal. Which of the following is best recommendation for this patient? Hemoglobin electrophoresis, MMR vaccine postpartum, repeat rubella and varicella titers in 4 weeks, Rogam now, tuberculin skin test, varicella vaccine now. First of all, varicella vaccine now, we cannot give it. Tuberculin skin test, there's no indication for that. Rogam now, it's 16 weeks, not indicated. Repeat rubella and varicella titers in 4 weeks. I mean, it says no immunity. If it says no immunity, then you don't really have to check again. It clearly says no immunity. The test is not equivocal. It's not uncertain. MMR postpartum, that is what we read in Toronto notes. Hemoglobin electrophoresis, it's 11.2. Mean corpuscular volume 84. Pretty good. And pregnant ladies, there is hemodilution too. So no need of this too. So this is MMR vaccine postpartum. The same thing again. Immunity to rubella is routinely evaluated in initial prenatal visit. Patients without immunity are vaccinated in the immediate postpartum period with the live attenuated MMR vaccine. Postpartum vaccination prevents future infection but avoids the theoretical risk of congenital rubella. But because if you give them intrapartum, then there is a risk of congenital rubella. So that avoids the risk of future congenital of the same baby's congenital rubella. Okay. All right. Moving forward, we're going to talk about radiations. Ionizing radiation exposure is considered teratogenic at high doses. If indicated for maternal health, should be done. So if it is indicated for maternal health, then it should be done. Higher dosage of radiation to fetus occurs with plain X-rays and CT and enema. And the X-rays and CT is specifically of lumbar, abdomen, pelvis. So these are not really good. These have higher dosage of radiation directly to the fetus. Radioactive isotopes of iodine are contraindicated, so you cannot even think of using those radioactive isotopes of iodine. Those are contraindicated. And X-ray and CT are they are associated with adverse effects. Then there are no known adverse effects of ultrasound and MRI, but long-term effects could be there. They are unknown, so we have to avoid them as much as possible. Here's a little table which includes approximate fetal doses and diagnostic procedures, common diagnostic procedures. So on plain film, you can see that this much is the fetal dose. So, and these are the number of exams safe in pregnancy. You don't have to learn this. Just a quick note over here, radiation in pregnancy. This just helps you to understand how it works. So necessary amount to cause a miscarriage, if it's more than 5 gray, I believe it's what this is what it's called, gray. So more than 5 C gray, then it causes miscarriage. But if it is more than 20 to 30, then it causes malformations. So this is how much you need to cause a malformation in the baby. That's how radiation affects in pregnancy.